before going to therapeutic drug monitoring or TDM, first thing we need to understand is how normally we monitor the effect of a drug or simply adjust the dose of a drug. So taking same example, we have a person who has blood pressure of 160 millimeter of mercury and we want to reduce this to 120 millimeter of mercury. That means we want to reduce 40 millimeter of mercury. And for this, normally we give drug A in a dose of 10 milligram. So a person has come to us with hypertension. We measure the blood pressure and we give drug A 10 milligram. Now how we will come to know whether we have given right dose or we need to increase or decrease the dose of this drug? How we normally come to know? By measuring the blood pressure. So we give 10 milligram of drug A for a week. Ask the person to come again after a week. We measure the blood pressure. If the blood pressure is near 120, that means the dose is okay. We will continue with that dose. But if the blood pressure is still 140, that means the drug is effective but not complete. So that means we need to increase the dose. And if the blood pressure decreases very much, that means we need to reduce the dose. So that is the normal method of adjusting the dose of a drug according to desired response. But this thing is not practical everywhere. Like another person has come to us with epilepsy. Person has seizure. And normally we give drug B 100 milligram dose in epilepsy. So person has comes to us with seizure and we have started drug B 100 milligram. Now how we will come to know whether we have given right dose or not? Obviously we will not wait that one more seizure should occur, then we will increase the dose. Or some serious side effect should occur, then we will decrease the dose. So the problem here is we cannot measure the response. So when we are not able to measure the response, then how we will adjust the dose? Now how we will adjust is we will check the plasma concentration of the drug. We know all the drugs are producing effect according to plasma concentration. From our already present knowledge, if we know that the drug B required plasma concentration is between 10 to 20 microgram per deciliter. So what we will do is we will give drug B 100 milligram for 5-7 days. Again we call the patient. Now we will check the plasma concentration. If the plasma concentration is between 10 and 20, that means the dose is okay. If it is less than 10, that means we need to increase the dose. If it is more than 20, that means we need to decrease the dose. So this method of adjustment of dose is called as therapeutic drug. So normally we adjust the dose of a drug according to response, but when we are not able to measure the response, we adjust the dose according to its plasma concentration, and that method of adjustment is called as therapeutic drug monitoring. So when we are adjusting the dose according to plasma concentration, we are doing the best thing. When we are doing the best thing, then why don't we use it for every drug? We should use it for every drug, but we do not use. In fact, we do the therapeutic drug monitoring only when we cannot do anything else. Now, why we normally do not do? One obvious thing is, first of all, we have to take the blood sample for measuring the plasma concentration. And for taking the blood sample, we have to prick the patient. When we can easily measure the blood pressure, then why to prick the patient? Second thing, after taking the blood sample, we have to measure plasma concentration. Measurement of plasma concentration requires sophisticated instruments like HPLC, spectrophotometer, and these instruments are very costly. And when they are so costly, there will be some experts which will be working on them. So these instruments, these expert people will not be available everywhere. Like if you go to a remote village, you will not be able to find this. And all these things will make it very costly. So suppose a person comes to me with hypertension, I give him a drug and say him that take the drug for 7 days and come with 50,000 rupees after 7 days, person will never return. So all these are practical problems. So TDM is not the first but the last method. When we cannot do anything, only then we will do TDM. So we should know what we can do. So first thing we can do is we can check the response. We can check the response. So if we can measure the response of a drug, no need of doing TDM. So TDM is never done for any drug where response can be easily checked. Like TDM is never done for drugs which are antihypertensives. We can measure the blood pressure. TDM is not done for drugs which are anti-diabetics. We can easily check the blood sugar. TDM is not done for anticoagulant drugs, like we can measure the prothrombin time and other times. Okay? So for these drugs, the response is measurable, so no need of doing TDM. But if the response is not measurable, like person is having epilepsy or the person is having cancer, then we can think of doing TDM. So suppose the condition is such that we are not able to measure the response, but the drug is very safe. Drug is very safe means the effect start at 5 microgram per deciliter and there is no side effect till the plasma concentration is 1000 microgram per deciliter. And if we give 100 milligram, the concentration comes near 5. Concentration comes near 5 means it may be 5, it may be 4, it may be 6. So we cannot rely on 100 milligram because if it remains less than 5, it will be ineffective. But who has stopped us? We can give 200 milligram. If we give 200 milligram, it may be near 10. It may be 6, maybe 8, it may be 15. So all of them are safe and effective. So if a drug is so much safe, then instead of measuring the plasma concentration again and again, simply increase the dose, give high dose. So this margin of safety is known as therapeutic index. Therapeutic index. So if a drug has wide therapeutic index, means drug is very safe, we give high dose of the drug. On the other hand, if a drug has narrow therapeutic index means the plasma effect start at 5, but the side effect will start at 10. So we cannot give 100 because if it remains less than 5, it will not be effective. We cannot give 200 because if it become more than 10, it will become toxic. So now we will think of doing therapeutic drug monitoring. So second criteria for doing therapeutic drug monitoring is there should be narrow therapeutic index. If the therapeutic index is wide, there is no need of doing TDM. Like penicillins are the drugs which have very wide therapeutic index. So we never do TDM for penicillins because they are very safe drugs. Whenever in doubt, we will simply increase the dose. Now suppose a drug's response we cannot measure, like drug is anti-epileptic and the drug is having narrow therapeutic index also between 5 and 10. But the drug is very consistent. Consistent in pharmacokinetics means whenever we give 150 milligram of this drug, the plasma concentration comes out to be 7. So to one person we give 150 milligram of the drug and measure the plasma concentration, it was 7. Second person we give 150 milligram, it was 7. Third person we give 150 milligram, it was 7. So we give 150 milligram to 100 people, in every person it was 7. So when it is coming out to be 7 in every person, rest also will do the same thing. So we will fix the dose that give 150 milligram. But on the other hand, if a drug has inconsistent pharmacokinetics, that means on giving same 150 milligram, in one person the plasma concentration is 7, in second person it is 4, in third person it is 12, then we cannot rely on 150 milligram. So we have to measure the concentration and accordingly adjust the dose. So for doing the therapeutic drug monitoring, we should have all three criteria present. That means we should not be able to measure the response. The drug should have narrow therapeutic index and the drug should have inconsistent pharmacokinetics, means the same dose is producing different concentration in different people. Only then we will do therapeutic drug monitoring. Clear? Another important concept to understand here is that the graph between plasma concentration and dose, should it be linear for doing TDM or it should not be linear? Like if the graph is like this, do we want that the graph should be like this for a drug to be a candidate of therapeutic drug monitoring? The answer is no. Because if the plasma concentration is increasing linearly with the dose, then why to measure? We can simply increase or decrease the dose. We will come to know whatever effect is coming at what dose. So the dose and plasma concentration graph may not be linear. Particularly if it is linear, then we need not check. We simply increase the dose, more concentration will come. But on the other hand, the graph between response and plasma concentration, it must be linear. Because if on increasing the plasma concentration, response do not increase proportionately, then there is no use of measuring the plasma concentration. So we are measuring the plasma concentration because we are considering that according to plasma concentration response is coming. So this is very important to understand that for therapeutic drug monitoring, the drug's response should be directly proportional to plasma concentration, or we can say it should be linear, but the graph between the dose and plasma concentration need not be linear. Rather, if it is linear, then most of the time we do not require to do the TDM. Okay. Another important thing is there are some drugs which are activated in the body. Like suppose a drug is inactive, which we say is a prodrug. It forms an active metabolite. Or we can say the drug was already active and it forms an active metabolite. Now, will you like to do therapeutic drug monitoring for such drugs? The answer is no. Because in therapeutic drug monitoring, we are measuring the plasma concentration of a particular substance. Suppose this drug was X and the active metabolite is Y, or this drug is X dash and active metabolite is Y dash. So we are measuring the plasma concentration of one substance. Suppose we measure the plasma concentration of substance X. So when we measure the plasma concentration of substance X, we do not know how much Y will be produced. Or if we measure the Y, we do not know how much to give X so that adequate amount of Y is produced. Or if we measure the both, we do not know how much percentage action is contributed by one, how much percentage is contributed by two. So it is usually not uniformly effective to measure the plasma concentration in case of drugs which are activated in the body. So usually TDM is not indicated for such drugs. Okay. And one more thing, we can do the therapeutic drug monitoring for measuring the compliance. Very commonly for conditions for which we are using the drugs long term, like epilepsy. A person is taking anti-epileptic drugs for 2 years, but after 3 months the person stopped taking the drug. We do not know whether the person is taking the drug or not, because the person says I am taking the drug. If we measure the plasma concentration and the concentration is not adequate, means the person was not taking. So we can measure the compliance by therapeutic drug monitoring. Okay. Now for which drugs we commonly do TDM? You can remember that TDM is done for drug possessing low therapeutic index. Drug possessing low therapeutic index, or you can make it a drug possessing low therapeutic index. So A stands for aminoglycosides, which are antibiotics. D for digoxin, which is used for congestive heart failure. E for phenytoin and other anti-epileptic drugs, most of the anti-epileptic drugs. L for lithium, which is used for mania and bipolar disorders. T for tricyclic antidepressants, which are not commonly used these days because of toxicity. And I for immunosuppressant drugs like cyclosporin and tacrolimus. These are the drugs for which we commonly do therapeutic drug monitoring. Aminoglycosides, digoxin, phenytoin and other anti-epileptic drugs, lithium, tricyclic antidepressants and immunosuppressant drugs. So this is the second very important topic for MCQ point of view. These are therapeutic drug monitoring.